of the West Indies. His roles over the years have included Principal Medical Officer, Epidemiology in the Ministry of Health, Chief Medical Officer, Director of the National HIV/STI Program, Scientific Secretary and Chair of the Caribbean Health Research Council, CHRC, and Temporary Advisor to the World Health Organization on a range of public health topics. He has also been instrumental in the HIV response in Jamaica, leading the response from its onset in 1986 until 2008, and transforming it into a highly successful multi-sectoral program. He currently serves as the chair of the Caribbean Immunization Technical Advisory Group, which advises Caribbean ministers of health, and as chair of the Caribbean Certification Committee for Eradication of Poliovirus. He has also made significant contributions to public health research with a body of research on a wide range of public health and infectious disease topics. Our presenter was recognized at the World Health Assembly as a health leader for his substantial contribution to public health in Jamaica, the Caribbean, the Americas, and the world over the past 4 decades. Ladies and gentlemen, help me make welcome Professor Peter Figueroa.
Good afternoon. Thank you for the invitation to talk about COVID vaccines, our best hope to control the pandemic. Are you hearing me and seeing the slides, please?
Yes, we are.
Okay, excellent. So I have no financial interest to declare. We know that the pandemic has transformed lives. There are over 200 million confirmed COVID cases globally, over 4 million deaths. And these figures are a definite underestimate of the actual number. It has crippled economies, disrupted lives, and increased inequality. We've seen an increase in poverty, hunger, unemployment, and I'm speaking globally, but Jamaica and the Caribbean have also been affected. A decline in gross domestic product, and of course, significant death and disease, including long COVID, where persons continue to have symptoms even after they have recovered. You can tell me better than I can tell you of the severe setback that we're facing in the education of our children and young adults. Of course, there have also been significant increases in mental illness, physical and sexual abuse, a drop in routine immunization coverage. So we've seen many challenges. This slide simply shows that prior to the pandemic in the United States, the difference of income was not making any difference in performance with online math coursework. But as soon as the pandemic came, you can see that those of lower income performed significantly poorer than those persons who were in the higher income group. And I think that this is something that we've seen in Jamaica as well. It is the poor and disadvantaged who are worse off in the pandemic. We've seen where vaccination coverage of our young children, essential vaccines, diphtheria, pertussis, tetanus, measles, mumps, rubella. The graph shows in red the significant decline in sustaining routine immunization coverage. Then we look at the epidemic curve for Jamaica, and you can see that we just are coming out of a major surge of cases, which peaked in March of this year. But before we've even realized that we're out of this, we are now into a massive new surge. We're approaching 60,000 cases. We've had over 1,300 deaths. And you know, one lesson we could take from the previous surge, if you don't act decisively early, when cases begin to increase, then what happens is the hospitals get overcrowded with severe cases and you get deaths. I think everyone now knows the clinical features of COVID. Most cases of COVID are mild or moderate. It's only maybe 14% that are severe and 6% critical, where people may actually die. But long COVID is something of concern. Perhaps 1 in 3 of severe cases continue to have symptoms. Case fatality increases with age. The symptoms are varied. It's just not fever, cough, fatigue, dyspnea. You can also, of course, have loss of smell or taste, headache, sore throat, confusion, diarrhea, a range of symptoms. Spread is primarily person to person, people who cough, sneeze, talk, or singing. The important thing to recognize is that some of the people who are transmitting, they may be just talking, singing, a sneeze, a cough. They may not be aware of the fact that they have COVID, that they're infected with the virus. They may be asymptomatic. It's primarily spread by persons with symptoms. But in the 2 or 3 days before you develop symptoms, you can also spread the virus. And then there are asymptomatic spreaders. There's no need for deep cleaning. Basic hygiene is fine. We know the measures to prevent spread: wearing masks, physical distancing, and avoiding crowds, especially indoors, with basic hygiene are the most important measures to try and avoid infection. Now, towards the end of last year, we began to see an increase in cases in many different countries, the US and Europe. And based on the experience going back to the end of last year, we noticed that once there was an increase in new cases shown in blue on this graph, you're going to get an increase in severe cases requiring hospitalization. And within 3 weeks, once you have an increase, a surge in cases, you're going to see a surge in the number of deaths. You cannot wait for us to start seeing increased deaths before decisive action is taken to control the surge. And we now know that towards the end of last year, in the UK, there was a new variant, Alpha, and in South Africa, there was another variant of concern called Beta that was responsible for the sudden increase in cases of COVID. Now, what is good and what is different from last year is that we have the rollout of COVID vaccines. And over nearly 4.4, now this slide is a week old, so it's % of vaccines have gone to high income and upper middle income countries. The vaccines that are found most commonly, well, before I come to that, what is happening is that some countries, high income countries, have pre-ordered far more vaccine doses than they actually need. Canada has actually ordered the equivalent of over 8 doses per person. The US, 7.5 per person. UK, Australia, and Europe, over 4 to 5 doses per person. So the advanced high-income countries are monopolizing the doses. And what this has meant is if you look at the proportion of people vaccinated in countries globally by the income of the country, you'll see that while high-income countries, they have increased their vaccine coverage in just 3 months from 20% to 40%. The middle-income countries, especially the upper middle-income countries, jumped when the China data was included. That's in purple. But low middle-income countries have only reached 10% of their population, and low-income countries have barely got 1 or 2% of their population vaccinated. So there's severe inequity in the distribution and availability of vaccines. However, once the vaccines began to be rolled out from December into January, you can immediately see a decline in the number of new cases of coronavirus in those countries where the vaccine was being rolled out. Can everyone check their mics to make sure they're muted? Please mute your mic. Thank you. I'm getting an echo. Okay, and as the vaccines were rolled out, the number of hospitalized cases began to decline. This shows data for the US. And the number of deaths and new cases also came down drastically from the turn of last year over the first 5 months of this year. Now, the approach towards vaccination varied a bit in the UK and the US. In the US, they tended to make sure that persons were fully vaccinated. So once you got the first dose, within 4 weeks, they would give you the second dose. In the UK, they took the decision that they would try and get more first doses to a larger proportion of their population before they did their second doses. And you can see that the curve of the decline in deaths in the UK was more dramatic than that in the US. And this shows the reduction of hospitalized cases and new cases, again in the first 5 months or 6 months of the year, really the first 5 months in the UK. And then the cases began to increase again significantly in the UK because of the spread of the Delta variant. However, deaths did not show the usual increase that is associated with the increase in cases. And this is because over 70% of the population in the UK have been vaccinated, and that prevented the steep increase in deaths that you usually see with a surge of cases. And this is also seen in the US, where you can see in blue the number of cases, new cases reported in the US. You can see during July that significant increase in cases, but the line in black, you can see that the number of deaths have increased, but they have not increased dramatically because it is persons who are not vaccinated who in fact are ending up in hospital primarily and dying. Persons who are vaccinated for the most part, have been protected from severe illness. So this brings us to the variants of concern. And I mentioned the Alpha, which took off towards the end of last year in the UK, and the Beta in South Africa towards the end of last year. Gamma is from Northeast Brazil, and it created havoc there. The Delta was identified first in India in October of last year, but it wasn't until about earlier this year, in around March, that we began to see the takeoff of the Delta variant, causing a massive surge of new cases in India. The concern with, or the dangers of the variants of concern, how this arises is that the virus that causes COVID, the SARS coronavirus 2, is an RNA virus, and it multiplies rapidly. Once you're infected, you get millions and millions of the virus replicating in your body. So mutations are very common. Most of these die out, but what happens occasionally is you get a mutation in this virus that makes it more infectious, so it spreads more rapidly. It may cause an increase in severe cases and deaths. And we have to monitor closely to make sure that a new variant, that the diagnostic tests continue to work. And of course, we have to monitor closely how well the vaccines are working. And the truth is that the vaccines are still working against the variants of concern, but they are not quite as effective against the Delta variant as they were against the other variants, but they are still critical. So once we saw the Delta variant emerge and surge in India, the COVID cases that were declining globally took off again, as shown in this graph. And it was largely due initially to the take-up of the cases in India. You can see the US in this curve was relatively flat, but it was only a matter of time, within a month or two, Delta spread to nearly every country in the world. And that is what is causing the primary challenge that we're facing with the COVID surge now in most countries. Now, the COVID facility was established in April of last year to promote vaccine development and manufacturing of vaccines. The aim was to ensure that all countries have access to safe, efficacious, affordable vaccines, and to provide at least 2 billion doses by the end of this year, so that we could get 20% of the population in every country vaccinated, hoping that this would end the acute phase of the pandemic. So the estimated number of vaccines to be produced this year may well be over 7.5 billion. COVAX goal was to secure 2 billion, and they've secured nearly twice as much as that, although they have not been able to purchase all of that yet. And they plan to distribute 187 million doses by the end of May. However, 2 months later, the end of July, they've still only been able to distribute 153 million doses. And the problem here is that the vaccine manufacturing capacity is limited, and the developed countries have purchased most of the vaccine. Some of the developed countries are even hoarding the COVID vaccine raw materials. Then India, which was to supply the COVAX facility, they had to use the vaccine they were producing to vaccinate their own people. So many developing countries have got little or no vaccine. Now, health workers and other frontline workers clearly need to be vaccinated early, because we've got to preserve the health service. The health workers are at risk. And if they're not vaccinated, they can become infected and then infect their patients. So it's very important to get all our health workers vaccinated. The elderly, this graph shows you the infection fatality rate. And if you look at it by age on the x-axis, the older the age, the higher the fatality rate. So if you're over the age of 60, you probably have 1 in 12 chance of dying from COVID if you get COVID. If you're over 70, you have a 1 in 8 chance of dying from COVID. So the elderly are definitely at risk. Persons with comorbidities, cardiovascular disease, diabetes, respiratory diseases, these people are more at risk of severe COVID. And of course, comorbidities increase with age. And this is why we say we've got to get the elderly vaccinated. Now, many people have concerns with the COVID vaccines. How could they have been developed so rapidly? And some people even say, well, wouldn't the body's immune system fight the virus out? Some people say the vaccine trials are too short to assess safety. And then why the new technology, messenger RNA vaccines, DNA vaccines, instead of the traditional vaccines? So, and then there are a variety of conspiracy theories, which is hard to know where these come from. Let me just point out, many of the vaccines, like many of the technological developments, have been the result of collaboration between private companies and government. The US Defense Department actually built the internet, and government research and development led to the development of a whole range of modern things that we take for granted, like airplanes, satellites, artificial limbs, flat TV screens, transistors, etc. So the Pfizer, BioNTech, and Moderna messenger RNA vaccines have actually relied on years of government-funded research into viral proteins and genetics. So this research has been going on since the 1990s. And the US and other governments spent billions of dollars to accelerate the COVID vaccine development. And this just is a table showing you the vast amount of money invested in the different private companies by the US government, by Gates Foundation, and by other foundations and other governments, all in order to accelerate the production of COVID vaccines. So COVID vaccines have been decades in development. When we had the severe acute respiratory syndrome outbreak in 2003, this condition was due to a SARS coronavirus. So this stimulated research into a vaccine from that time. And again, the Middle East respiratory syndrome in 2012 stimulated further research. So when the Chinese scientists in January of last time sequenced the genome of the virus that caught the coronavirus, they made it available to the scientific community. So those companies that had developed a coronavirus vaccine against SARS simply changed the coding so that it could become a COVID vaccine and started testing it out in animals in the lab right away, and then put it in trials immediately by March of last year, it was in vaccine trials. This is how they were able to get this vaccine developed so quickly. Now, this thing about the body's immune system fighting the virus off, it is true. In many instances, the majority of instances, especially if you're young and healthy, your body does fight off the virus. Your immune system reacts to the virus. You may get sick, but then you fight it off. But you are likely to get sick. before your immune system develops the capacity to protect yourself. And if you're elderly or have comorbidities, not only may you get sick, you may get severely sick and you end up in hospital, and unfortunately, you can die. So instead of letting the virus infect our immune system and run the risk of getting seriously ill, what you do is you take the vaccine, which gives your immune system a dry run, because it's not a dangerous virus that you're getting. It is a mimic of a virus that does not cause infection of your immune system. It gives a dry run to your immune system, so that when your immune system actually sees the real virus, it is already prepared and can protect you. Now, this slide, we don't have time to go through it, but I just want to point out, if you look at those boxes starting on the right-hand side, you have a variety of different traditional vaccines. You can have a live vaccine. The oral polio vaccine is alive and it multiplies in you, but it is attenuated. It is weakened in the lab. So it usually does not cause a problem. The injection, the inactivated polio vaccine, is an injection which we are now using as well as the polio drops. That is inactivated. The virus is killed and injected into your muscle. But the technology is developing. They've been able to use what we call viral vectors, like adenoviruses that usually cause a common cold. What they do now is they may put a little protein in there or a little messenger RNA in that viral vector and get that into your system. The viral vector usually cannot replicate, but there are viral vectors that can replicate, but we don't use those usually. Then you have the messenger RNA that can be injected in. They have virus-like particles or protein subunits. So these are just a variety of different approaches to vaccinating. Let's talk about those vaccines quickly that we have. The messenger RNA is encapsulated in a microscopic nanoparticle of lipid or oil or fat. Injected into your arm, there are no infectious particles, no adjuvant. It's rapidly broken down. It does not go into the nucleus of the cell. It just goes into your muscle and it stimulates the production of a protein that mimics the spike protein of the coronavirus. Your immune system responds to that. And within 4 weeks, you develop some immunity. When you get the second dose, you develop full immunity. The one side effect that you have to be aware of is that for every 2 to 4 million doses, you may get a severe allergic anaphylactic reaction. Nobody has died from this yet because you usually have adrenaline, steroids, and antihistamines right on site if someone develops that kind of reaction. They've also found in young people that some people get a little inflammation of the heart muscle or the covering around the heart, but no one has died from that, and it only lasts a day or two. It seems to be self-limiting. Now, the AstraZeneca vaccine, which we've been using, is a non-replicating adenoviral vector vaccine containing some RNA. You inject it into your arm, no infectious particles, no adjuvant. This vaccine has been given to at least 1 billion people now. And if you can get it, the second dose 4 weeks, but you get a stronger response if you wait 8 to 12 weeks after the first dose to take the second dose. Now, this is a very effective and safe vaccine, but there are very rare complication of a blood clot. But you've got to know that more blood clots are less common among persons getting the vaccine than among the general population. It's just that maybe 5 to 6 cases per million doses, you can get a very serious blood clot. And I'll tell you a little more about that. But I want to tell you first about the local reactions, because some people, after they get the vaccine, do have a bit of discomfort in their arm, or they may get a headache or fever, or you just feel tired. This usually lasts a day or two. This is your immune system responding to the vaccine. Where the concern is in relation to the very rare blood clot condition, which occurs maybe 5 to 6 cases for every million doses. People who develop these blood clots develop severe persistent headache or severe persistent abdominal pain. So you can alert your doctor immediately, because the severity of the symptoms send you to the doctor. Once the doctor is alert, then you can immediately get to hospital and get the treatment. But you know, anyone who develops severe COVID, 50% of the persons who develop severe COVID develop blood clots. And it's often the blood clot that actually kills the person who is in hospital who has severe COVID. The J&J vaccine is a recombinant. It's like a vector. It's a vector virus again, vector vaccine. But what they do know is the vector cannot replicate, and they put a protein. They put the equivalent of like the spike protein from the SARS virus within the vector. So the body reacts to this spike protein and develops immunity against the spike protein, so that when it actually does see the spike protein in the virus, it is prepared. There are no adjuvants, preservatives, or material from animal or fetal tissue in the J&J vaccine. It's a very good vaccine. One dose gives you approximately 6 to 7% vaccine efficacy. It's not quite as effective against the Delta variant, but it still gives very good protection. And very rarely do you get the blood clot, or you get another condition called Guillain-Barré syndrome, which we're very familiar with, where you get some weakness in your lower leg that after a few days or a couple of weeks, it passes. It's a good, safe vaccine. Now, people with comorbid conditions, diabetes, sugar, hypertension, whatever it is, you can take the vaccines because you're more at risk. If your immunity is very low because you have cancer treatment, chemotherapy, or any other reason for severe depressed immunity, then you should wait until your immunity has recovered somewhat before you take the vaccine. Obviously, if you're ill with COVID, it's better to recover before you take the vaccine. And you can wait 4 to 6 months before you take the vaccine, which acts as a booster to to enhance your immunity. Breastfeeding women can take the vaccine. Pregnant women are advised to take the vaccine because persons who are pregnant seem to do worse if they become infected with COVID. Teenagers can now take the messenger RNA vaccine. Now, 1 dose of AstraZeneca vaccine is usually 70% effective, but with Delta, it is probably only about 33% effective. 1 dose of Pfizer is probably about 40% effective against Delta. Once you have 2 doses of AstraZeneca or Delta or Pfizer, then you're over 80% protected against Delta virus. 1 dose often protects you from severe COVID. 2 doses almost always protects you from severe COVID. The duration of protection appears now to be at least 9 months, and it is probably longer. No, there's still a need for public health measures, right? Even after you're vaccinated. And in Jamaica, only 10% of the population is vaccinated. So people still have to wear masks. It's going to take time to roll out the vaccines. So we still have to take precautionary measures and follow the protocols. It's really important to do this. Avoid close contact and crowds in closed indoor spaces. That is really important. So we're going to have to live with COVID for the foreseeable future. It's better to vaccinate more persons with 1 dose than fewer persons with 2 doses. But as soon as you have the opportunity to get vaccinated, it's better to be vaccinated than not be vaccinated. Nothing is in life is 100%, so the vaccine is not a silver bullet. We still need the non-pharmaceutical measures. Dogs can be trained to smell persons with COVID, and we're going to continue to learn more about COVID. The situation is dynamic. But I would really encourage you, as teachers, it is really critical because we've got somehow to get our education system going. And we are now facing a very serious surge. So I guess it's going to be more blended work. It's really tough. You have a tough job doing. But as soon as we can, we need to get our children back in school, not only with online education. So it's really important that all teachers, just like nurses and doctors, that you get the vaccine at your earliest opportunity. Thank you.
Colleagues, we would have heard the presentation from the professor. I don't know how we may be able to facilitate questions of Prof. Janice, online.
Sure, just ask and we'll hear. Nash can respond.
Mr. Yeah. Prof, you're online still. We will be taking questions, sir. And I hope that they'll be very quick so that you can give a response. The JTA thanks you very much for the very good presentation. I hope you're hearing us.
Yeah, I'm hearing you now.
Okay, so I guess colleagues will have to applaud Prof again. Yes, sir, your presentation was very good, very pointed, and the JTA appreciates you for taking time out to share with us this morning. We will be facilitating some questions, and we crave your indulgence to assist in answering them. Colleagues, if there's any question for Professor Figueroa, please get behind the microphone, and the usual rules apply. Social distancing, the president-elect will help me to identify the persons who are there. We will start with the microphone to my right, your left, then we go across. And colleagues, please, let your questions be pointed to the point. Just get to the point. Take your seat, and we'll allow Prof to answer them. Thank you very much. You may proceed.
Thank you, Mr. President. Good afternoon, colleagues. Good afternoon, Dr. Figueroa. A member gave me this question. Can a teacher get the second dose a month after the first dose, even if the second dose is due 8 weeks after? And if yes, how?
Well, I think you can get it. What you'd have to do is try and make an early appointment, or when you're getting your first dose, then you should probably ask them to give you an appointment, which is at 4 weeks, because the ministry is using, on average, they're giving appointments, I think, for 8 weeks. So if for some special reason you need to get the second dose in 4 weeks, whether due to travel or something, then it's better when you get the first dose to just ask that you could get an early appointment for the second dose. Otherwise, you'd have to phone the helpline and ask them to change your appointment. Over.
Yes, colleague, you may proceed. Is that Tamara?
Yes, it is. Good afternoon, colleagues. Good afternoon, Doc. My question is, with about 80%, I can't remember exactly what was quoted, that with the 2 doses, that we are guaranteed some form of surety. Is there the need or future plan that we will be required to be vaccinated again?
Yeah, no, this is something that is being monitored. And you see, remember, most vaccinations have just been rolled out since the beginning of this year. We have good reason to believe that people will be protected for over a year and even longer, but we don't know. We simply have to learn as we're going along. People who have been infected with COVID from last year, we know that most of them continue to be protected from COVID past 1 year, past 15 months. We're hoping that the same will be true for the vaccine, but we don't know. We have to monitor and see. But what is happening is that my own assessment is that some of the vaccine companies are pushing for an early booster dose, like Pfizer and Moderna, because they notice that the neutralizing antibodies in the body begin to decline a bit after 6 months. But that doesn't necessarily mean that you're still not protected. It is possible that the level of protection is not quite as strong, but you're still protected against severe disease. And there are not enough vaccines to go around now. So many of the low-income countries still have got very few vaccines. And if the rich countries start giving booster doses from now, it means it will take longer for the low-income countries to get vaccines to their population. So this is something being monitored, but right now, at this point, persons who have been fully vaccinated, most of them, the vast majority, remain protected from severe disease.
Thank you. Thank you. Colleague, you may proceed.
Good afternoon, Council. Good afternoon, Doc. Diana Campbell, conference. Diana Campbell. Can someone who is epileptic and have seizures now and again on medication take the vaccine?
Certainly, they can. There's no reason not to.
Okay, thank you. Thank you. Thank you.
Thank you. Colleague, is there any more? Is there any other questions for Professor Figueroa? IPP?
Thank you very much, Prof, for your presentation. Jasford Gabriel, immediate past president. Your take on the vaccination for students, and how important is this if we're seeking to facilitate face-to-face instructions?
To be frank, I think the ideal thing would be first to get the teachers vaccinated, all the teachers, but it would be ideal if we have enough vaccine to actually give to the children. But it would have to be children over age 12 because the trials in the younger children have not been completed. So there's a problem we face. We don't have enough vaccine. So we'll have to prioritize the different groups. In my view, the first priority are the health workers, the doctors, the nurses, and those who are giving direct patient care.
He has a follow-up, Professor.
Education is so critical. The teachers need to be vaccinated, especially the teachers who are over 40 or who have comorbid conditions. The younger teachers, I think, could wait a little longer, but I know the government is trying to vaccinate all teachers. And ideally, it would be good to be able to vaccinate the teenage children who are doing face-to-face.
Just a quick follow-up. So I'm sure you'd have taken note in the face-to-face interactions that we have had this school year. The vast majority of the cases of COVID-19 would have been among students, many of them asymptomatic in nature and so on. And we know the issues in terms of transportation, which still is not resolved. So why is it that right now we are at roughly 70% of our teachers vaccinated? Why is it a priority still for teachers and not for students to be vaccinated?
Well, I think it's a question of, remember, the availability of the vaccine, and the only vaccine that has been authorized to give children is either the Pfizer or the Moderna. So up until this point, we have not had any Pfizer, but I understand Pfizer is either here now or it's about to be here. So I don't know what the ministry plans to do with the Pfizer. But I would think that those students, starting with those students who are going to be in their exam year, I would start with those students because those are the students who would benefit most from coming out and having face-to-face classes, and you could vaccinate them. Now, at schools, once, if you're able to open up, and you're even taking 50% of the children on any one day, and you're doing blended teaching, the teenage children, any child over the age of 5 years should be using a mask, should aim to maintain physical distancing and hand hygiene. And as you pointed out, we have a serious problem with respect to transportation. And I think it would be better to organize transportation for the children alone where feasible.
Thank you. We have 3 more questions. Is there any other person? Okay, going once, going twice, gone. Just the 3 persons who are standing. We go with my colleague from Hanover Street, Kingston Stats, or Kingston Technical, then Mr. Norman, and then we come back. Proceed.
Good afternoon, all. Good afternoon, Dr. Figueroa. My name is Beverly Gustav from Kingston Technical. I just have one question to ask. What, if any, would be the side effects for asthmatic patients,
colleague,
students?
could you just pause for a moment, please?
Yes.
Based on our time, in keeping with our standing orders and to make sure that we are legal, colleagues, I now move a motion for the extension of this session by 30 minutes. Thank you, Trustee Howell, and seconded by
Gustav.
Gustav. All in favor?
Aye.
Any against? The ayes have it. You may proceed.
Yes, sir. I was asking, what, if any, would be the side effects for persons who are asthmatic, I mean teachers and students alike, if there's any? Because why I ask this, would there be any?
Is very important for people like asthmatics, because if an asthmatic person gets COVID, you know, they're already compromised with their breathing at times when they have attacks. So it's really important for people with asthma, and similarly persons with respiratory conditions, other respiratory conditions, to take the vaccine, definitely.
Thank you, sir.
Norman?
Norman Johnson. Delegate Whitehouse. I want to find out, persons who would have contracted the virus and has recovered, it is said that such a person would have developed some level of immunity. Why then would such a person still need to take the vaccine? Secondly, since there is a 9 months guarantee in terms of protection, having taken the vaccine, would there then be need for a booster, or it should not? Need.
Yeah, it's an excellent question. I like that question. You make an excellent point. Someone who has had COVID, usually they develop immunity against COVID. The reason why it is suggested to take 1 dose in 4 to 6 months is because we have seen instances of a few people, some people who have had COVID and then they get reinfected again. They get COVID twice. It's not that many people, but it seems as if like when another variant comes along and they get infected. So it is true that 1 dose 4 to 6 months after being infected with COVID is like a booster dose. But as you correctly say, if we notice most people are protected from COVID still 9 months after the vaccine, or even longer if they had COVID, then if they did not take the vaccine, most of them would probably still be protected.
Thank you. Final question. My good lady, you may proceed. Thank you.
Sure, thank you very much. Ray Richard Spirit from St. Catherine, Jonathan Grant High School. Question is, for persons who are asthmatic and say a cancer survivor, is there any specific vaccine that you'd recommend for them to take?
I think you could take any. A cancer survivor and asthmatics, any of the vaccines are fine. They're all good. The conditions where I recommend one vaccine over another are very unusual. There are certain conditions that I won't go into. Let's just call it fine print. In other words, very specific situations where I may say, okay, take this vaccine over the other one. The one exception is that for children, teenage children, only the Pfizer vaccine or the Moderna vaccine at this time. In due course, when other trials are done among children, then we'll have additional vaccines done among children. But anyone who has any illness right now, most of the common illnesses like asthma, fibroids, lupus, sickle cell, hypertension, sugar, all of those illnesses, you can take any of the vaccines. And I would encourage you to do so. So,
mention cancer, to be specific. Would there be finer details to consider for a cancer patient?
The only thing about cancer patients is if they are getting chemotherapy, active chemotherapy or radiation, that usually weakens the immune system. So it's better for them to complete the radiotherapy or the chemotherapy and recover their immunity and then get vaccinated. In certain cancers and certain situations where there is reduced immunity, then they're thinking of giving a booster dose because the people with reduced immunity don't develop a strong immune response against the COVID. But those are specific situations. It doesn't apply to most situations.
So those questions, because I'm a cancer survivor, would it best then to consult with my doctor first?
Or consult with your doctor, and don't be shy to tell your doctor to check. If they are not sure, check with someone who is likely to be better informed, because this is a special field and not everyone is up to date, and all of us have to keep looking up what is the latest information that is there. So quite a number of my colleagues have phoned me, and there are other persons who are more up to date with the developments than some of the doctors. But most doctors try their best to keep up to date.
Thank you, Professor. And I had said all the persons who wish to speak should get behind the microphone. And we went 1, 2, and 3. For this time only, I will facilitate this question.
Mr. President, Ray Howell, a colleague got both doses of the vaccine, went to the United States, came back after 2 days, developed symptoms, was tested positive for COVID-19. What percentage of the population have been affected despite getting both shots?
Well, with the Delta variant, it seems to be more transmissible. So someone could get 2 shots of a vaccine, and if they did this in Jamaica, that would most likely be the AstraZeneca. Now, they could get exposed to the virus and become infected. Usually, they would not get severe disease, but they could have some symptoms, or if they were traveling and required to do a test, they could be asymptomatic, and that test may show positive because they may be infected with the virus. We don't know exactly what proportion of people that happens to. It does happen to some, especially with the Delta virus, but we think it's a minority of people. But this is one reason why we say continue to wear a mask and follow the protocols in relation to avoiding crowds and maintaining physical distancing. Part of the problem that we're facing, you see, what we're beginning to realize, we are infected usually by droplet spread coming into your nose or your mouth or your eyes. When we give an injection into the muscle, you get an antibody produced, first the IgM and then the IgG. And that gives you good systemic protection, including in your lungs. But it may not give you what we call mucosal infection to protect your nose, your nasal mucosa. And they're now beginning to explore the possibility of using a nasal spray as a vaccine to get more protection against the mucosa, to prevent against infection. We see the same thing in polio. The polio injection is excellent, but it's the oral drops that gives you better mucosal protection to droplet spread for polio, as well as it protects your gut. So the vaccines are not 100%, but they are superb in helping to prevent against severe disease. Unfortunately, some people vaccinated can still get infected, may still have some symptoms. So we have to have the protocols while we find a way to get even better vaccines.
Thank you, Prof. Again, we thank you for sharing with us this morning. And we salute your wisdom, your knowledge, and your willingness to educate us, the teachers of Jamaica, on a very important matter as it is now. And I must say again, Prof, you say that the teachers should be vaccinated. And I was advised as recent as last night that there is a 68% take-up of teachers who have been fully vaccinated, or at least have gotten a dose.
98%.
We are at 98 now, Prof? Oh, want to be there. I'm sure your presentation would have helped to bring that up further. Thank you, sir.
Okay. And all the best.
You're welcome. Colleagues, we are proceeding warp speed. We want to complete the presentation of the discussion concerning the annual report presented by the Secretary General yesterday. We left off at that, and we were at questions and answers. Questions from the report. Now I'm going to invite all the persons who wish to ask a question of the Secretary General from the annual report to get behind the microphone quickly. And after we accept, after a decision is made on the annual report, we'll take the budget. So we're asking the Chairman of Finance to stand by. And remember, colleagues, if you wish to question anything from the annual report, get behind the microphone, because once it is over, we will not be facilitating any late interjection. Thank you. Is there anyone to question the annual report? Is there anyone to question the annual report? All right. Thank you, colleagues. Could we then, I am now therefore moving a motion. Oh, just a minute before we move the motion, the Secretary wishes to say something.
Thank you, Mr. President. Colleagues, in my report, there would be some kind of indication, like, for example, some resolution amendment to the articles to facilitate some bimodal approaches and so on. The chair, through the policy committee, will bring those hopefully during the resolution sections. I just want to say, though the report will be accepted, there is a spirit that there are some attachments that will come later. Thank you, Mr. Chair.
Thank you, Secretary General. The motion is therefore before us, colleagues, for the acceptance of the Secretary General's report or the annual report as stated in our program. Moved by Laverne Johnson, seconded by Bevin Miller. Could the Chairman of Finance make his way to the podium to present the budget for the 2022-2023 conference year? Okay. Is the Chairman of the Salaries and Conditions of Service Committee available?
No. It's salary.
I'm just checking if the Salaries and Conditions of Service Committee